Hello, welcome to my channel. I'm Dr. Dural, radiologist. This is a sonography radiology training channel. I will present different videos could be benefit for physicians and general population. This is the first video about imaging findings in leukemia, mostly about leukemia symptoms and imaging findings in central nervous system. CNS Manifestations of Leukemia Part 2. In this video, I will explain CNS manifestations of leukemia related to side effects of therapeutic measures, which can be classified as two groups, including radiation therapy and those related to chemotherapy and bone marrow transplantation. Side effects related to radiation therapy include white matter disease, mineralizing microangiopathy, parenchymal brain volume loss, radiation-induced cryptic vascular malformations, and second, neoplasms, and those related to chemotherapy and bone marrow transplantation, including hemorrhage, dural venous thrombosis, white matter disease, reversible posterior leukoencephalopathy syndrome, and anterior lumbosacral radiculopathy. Now, the first group, side effects related to radiation therapy. The first one is white matter disease. Neurotoxic reactions to radiation therapy can be divided into acute from 1 to 6 weeks after treatment, early delayed injury 3 weeks to several months after irradiation, and late delayed injury months to years after treatment. In acute injury, there is increased capillary permeability and vasodilatation leading to vasogenic edema. Early delayed injury includes vasogenic edema and demyelination. Late delayed effects include white matter necrosis, demyelination, astrocytosis, and vasculopathy. Acute lesions are in general mild and reversible, with areas of periventricular white matter edema seen at CT or MR imaging, whereas the delayed toxic effects are more severe and usually irreversible, resulting from white matter, vasculopathy, and infarction. Patients with delayed toxic effects can manifest vocal deficits or stupor, but no direct association between mild or moderate changes at imaging and clinical symptoms has been found. Now, a case presentation: delayed therapeutic injury in a 9-year-old boy with seizures who had been treated for acute lymphocytic leukemia with chemotherapy and radiation therapy. These axial T2 images show abnormal signal intensity of periventricular white matter with some parenchymal volume loss. One of the most severe processes, named necrotizing diffuse leukoencephalopathy, which is seen with combined chemotherapy and radiation therapy, is associated with subsequent rapid and progressive clinical deterioration. Extensive areas of white matter necrosis can be seen at neuroimaging, with marked enhancement after contrast medium administration and a tendency toward posterior calcification. Like this patient, leukoencephalopathy in a 2-year-old patient who received high-dose intrathecal methotrexate therapy for acute lymphocytic leukemia, which shows periventricular white matter changes of leukoencephalopathy. The second side effect related to radiation therapy is mineralizing microangiopathy. Radiation therapy produces hyalinization and fibrinoid necrosis of small arteries and arterioles with endothelial proliferation and calcium deposition. Dystrophic calcification in the basal ganglia and subcortical white matter were a relatively common finding at cranial CT in children previously treated with radiation therapy and intrathecal methotrexate. Nowadays, with the more conservative protocols, a subtle pattern can be discovered on follow-up MR images, with potencial increased signal intensity on T1 images and decreased signal intensity on T2 images. These imaging findings appear 2 or more years after the cranial irradiation and are more common with combined chemotherapy, especially intrathecal and radiation therapy, and do not clearly correlate with clinical symptoms. This is an example of subtle mineralizing microangiopathy in a 10-year-old patient who had been treated for acute lymphocytic leukemia with radiation therapy and chemotherapy. Another side effect related to radiation therapy is parenchymal brain volume loss. Children receiving CNS prophylaxis with irradiation or intrathecal chemotherapy may posteriorly develop cerebral volume loss even when CNS leukemic involvement was not originally present. This finding correlates with posterior neurocognitive deficits more severe in the youngest group of patients. Also, enlarged CSF spaces usually result from therapy, mainly corticotherapy. 31% of children with acute lymphocytic leukemia have slightly enlarged ventricles before treatment, probably related to hydrocephalus secondary to primary disease. Nevertheless, when the enlargement does not reverse after remission but instead persists or even increases, it is probably related to cranial irradiation and is responsible for posterior learning problems in up to 80% of survivors. This is an axial CT, shows cerebral parenchymal volume loss in a 5-year-old patient receiving radiation therapy and intrathecal chemotherapy for acute lymphocytic leukemia. We can see ventricular and subarachnoid spaces dilatation. These imaging findings did not reverse at follow-up examinations. Another side effect related to radiation therapy is radiation-induced cryptic vascular malformations. Children treated with cranial irradiation due to leukemia or CNS primary neoplasms can develop white matter hemorrhagic lesions with heterogeneous signal intensity quite similar to that of cryptic malformations or cavernous angiomas on MR images. These features are probably capillary telangiectasias secondary to the altered venular endothelium with subsequent venous occlusive disease. Gradient echo sequences are particularly useful for identification because of their great magnetic susceptibility. The lesions can be isolated or multiple and show calcifications at cranial CT. This is an example of radiation-induced cryptic vascular malformations in a 15-year-old boy with headaches who had been treated for acute lymphocytic leukemia. These axial T1 and T2 images shows a hyperintense lesion with a hypointense ring in the left thalamic nucleus. Also, in this area, a hypointense lesion in the subcortical white matter of the right frontal region is also seen. This is gradient echo MR image from the same patients shows both lesions more clearly. These hemorrhagic lesions were unchanged and follow MR imaging examinations. Patients are usually asymptomatic, although some have headaches, seizures, or focal signs. These lesions, which appear several years after treatment, can have hemorrhagic potential, but surgical removal is justified only in cases of symptomatic hemorrhage. This axial T2 image shows the heterogeneous mass has a rim of low signal intensity consistent with hemosiderin that surrounds a central zone containing material of high and low signal intensity consistent with thrombus, and whole blood products. Note that the lesion does not generate vasogenic edema, as it is a slowly progressive process. The last side effect related to radiation therapy is second neoplasms. Second neoplasms are relatively rare neoplasms that are mainly related to radiation therapy and have an overall prevalence of 3 to 12%. Among the second intracranial tumors, 70% correspond to meningiomas, 20% to gliomas, and 10% to sarcomas. The latency period between treatment and development of these tumors can be variable. Markedly increased risk is seen at children who underwent cranial irradiation at 5 years of age or younger, those with a genetic predisposition to tumors like bilateral retinoblastoma or type 1 neurofibromatosis, or survivors of bone marrow transplantation. Unfortunately, treatment-induced tumors are more aggressive and highly refractory to therapy. Secondary meningiomas are also characterized by younger age at presentation, higher male to female ratio, and biologically more aggressive variants compared to primary spontaneous meningiomas. Now a case presentation: secondary meningioma in a 17-year-old patient with occipital headaches who underwent therapy for acute lymphocytic leukemia, including cranial irradiation at the age of 2 years. Also, she was treated for papillary carcinoma of the thyroid 2 years earlier. This axial T2 and post-CAT T1 images show an extraaxial mass in the posterior fossa. The mass has slightly low signal intensity on T2 and demonstrate homogeneous enhancement on post-CAT T1. The tumor was resected and the histopathologic diagnosis was meningioma with anaplastic foci. Follow-up MR imaging examinations did not demonstrate tumor recurrence. The second group of side effects, those related to chemotherapy and bone marrow transplantation. The first one is hemorrhage. In patients with hematologic malignancies, hemorrhage can also occur during chemotherapy or bone marrow transplantation. The effect of some chemotherapic agents, such as L-asperginase, aggravates the underlying thrombocytopenia and the anomalous production of breakdown of coagulation factors with subsequent bleeding diathesis. Leukemic patients may also develop disseminated intravascular coagulation with resulting hypofibrinogenemia and a pattern of multiple small hemorrhages in the subcortical white matter. Subdural or subarachnoid extraaxial hemorrhage is less common than intraaxial. Now a case presentation: parenchymal hemorrhage after bone marrow transplantation in a 10-year-old boy with acute lymphocytic leukemia and severe thrombocytopenia who experienced sudden neurologic deterioration. Axial CT scans show a huge parenchymal hemorrhage in the left hemisphere with surrounding edema and mass effect. The patient died in the intensive care unit, unfortunately. The second side effect related to chemotherapy and bone marrow transplantation is dural venous thrombosis. Sino-venous occlusion is now reported more frequently in oncologic pediatric patients, particularly in leukemia. Contributing factors include CNS infiltration, leukostasis, and chemotropic agents such as L-asparginase and vincristine. Diagnosis requires a high index of suspicion, and radiologists should look for subtle signs at CT such as venous infarcts, abnormal sinus high attenuation on pericontrast scans, and abnormal central sinus low attenuation or empty delta sign on post-contrast scans. MR imaging with fluid-sensitive gradient echo techniques or MR venography can easily show the lack of fluid in the affected dural sinuses. This is an example: dural venous thrombosis in a 10-year-old patient with headaches and seizures who had been treated for acute lymphocytic leukemia with L-asparginase. Sagittal T1 show high signal intensity along the superior sagittal sinus, a finding suggestive of subacute thrombus. This axial T2 shows frontal subcortical hemorrhagic lesion and high signal intensity within the sagittal sinus, which is suggestive of lack of follow. An MR venography shows thrombosis involving the superior sagittal sinus. Anticoagulant therapy was started, and follow-up MR imaging shows resolution of the thrombosis. Another side effect related to chemotherapy and bone marrow transplantation is white matter disease. Chemotherapeutic agents, particularly methotrexate and the other, occasionally cause cerebral white matter anomalies. These abnormalities, which can be asymptomatic or symptomatic, transient or permanent, are characterized by diffuse symmetrical involvement of the central and periventricular white matter, usually relative preservation of subcortical fibers. Treatment exclusively with high-dose chemotherapy in leukemic patients, usually consisting of both intravenous and intrathecal methotrexate, can cause acute or subacute transient benign neurotoxic effects or early more severe encephalopathy with permanent neurologic deficits. More significant alteration of intellectual performance after cranial irradiation than after intrathecal methotrexate therapy has been reported in children with acute lymphocytic leukemia, although neurologic sequelae can be seen in both groups. Now a case presentation: pure methotrexate leukoencephalopathy in a 6-year-old boy who had been treated for acute lymphocytic leukemia only with chemotherapy, including intravenous and intrathecal methotrexate therapy. He developed progressive neurologic deterioration with motor dysfunction and lethargy. These axial T2 and FLAIR MR images show hyperintense symmetrical lesions involving the periventricular white matter. Another side effect related to chemotherapy and bone marrow transplantation is reversible posterior leukoencephalopathy syndrome. Reversible acute neurologic complications in pediatric patients under treatment for myeloproliferative disorders occurring with immunosuppressor medication, mainly cyclosporine. The clinical syndrome was first described as acute neurologic changes in the setting of sudden or prolonged arterial hypertension that overcomes the auto-regulatory capacity of the cerebral vasculature. The relative passivity of sympathetic innervation in the posterior circulation may account for the preponderance of posterior cerebral changes. Neurologic manifestations include headache, nausea, vomiting, seizures, visual changes, confusion, and coma. CT and MR imaging shows subcortical white matter edema, predominantly in posterior temporal, parietal, and occipital areas, although more severe cases can also affect the basal ganglia, cerebral hemispheres, and brain stem. This is his presentation: reversible posterior leukoencephalopathy in 12-year-old boy with acute lymphocytic leukemia and a bone marrow transplant who presented with visual disturbances and seizures. The clinical symptoms coincided with arterial hypertension. Axial CT scan show hypoattenuating cortical and subcortical lesions in the parietal lobes. Axial FLAIR images show the lesions more clearly. Characteristically, these affected areas usually have increased or facilitated diffusion at diffusion-weighted imaging because of the absence of cytotoxic edema. This is diffusion-weighted image of the same patient, shows an elevated apparent diffusion coefficient in regions with the corresponding signal intensity abnormality on T2 images. The patient recovered from the neurologic symptoms after blood pressure was controlled, and follow-up MR imaging demonstrated complete resolution of the lesions. Prompt control of blood pressure and withdrawal of immunosuppressive drug often result in complete neurologic recovery with resolution of the neuroimaging abnormalities. This is an example of reversible posterior leukoencephalopathy with cerebral involvement in a 10-year-old boy with acute lymphocytic leukemia and a bone marrow transplant who presented with posterior headaches and cerebral signs. This axial CT shows symmetrical hypoattenuating cerebellar lesions. An axial T2 image obtained 24 hours later shows improvement of the lesions. Nevertheless, if left untreated, arterial hypertension can lead to progressive neurologic deterioration with infarction or hemorrhage and possible irreversible neurologic deficit. The increase in reported cases of reversible posterior leukoencephalopathy syndrome warrants further investigations into its risk factors and polyphysiological mechanisms, as well as further education of oncology healthcare providers. The last side effect related to chemotherapy and bone marrow transplantation is anterior lumbosacral radiculopathy. Intrathecal methotrexate administration can produce anterior lumbosacral radiculopathy attributed to direct toxic effects on the spinal cord. The clinical picture consisted of progressive flaccid weakness of the lower extremities without sensory deficit. All of these patients showed enhancement of the anterior lumbosacral nerve roots on gadolinium enhanced image. This is an example anterior lumbo-sacral radiculopathy in a 7-year-old boy with acute lymphocytic leukemia who was undergoing treatment with intrathecal methotrexate. He developed progressive areflexive paraparesis. These sagittal and axial postcard T1 images show selective enhancement of the anterior lumbosacral roots. The clinical symptoms improved and follow-up MR images were normal. Nerve conduction and electromyographic abnormalities usually correlates with the root enhancement at MR imaging. Spinal MR imaging allows quick differential diagnosis between this anterior toxic radiculopathy and the potential epidural subdural hematoma occurring after lumbar puncture secondary to thrombocytopenia. The last section is infectious complications. Infectious complications are one of the most significant causes of morbidity and death in the pediatric cancer patient. Both the underlying malignancy and the anti-neoplasm therapy can cause immunosuppression. The risk of infection increases as a function of the degree and duration of granulocytopenia. Fungi are the most frequent causal microorganisms and typically affect patients having absolute granulocytic counts of less than 100 per cubic millimeter for more than 2 weeks. Additional risk factors include prolonged hospitalization, administration of broad-spectrum antibiotics, chemotherapy or radiation therapy-induced mucosal damage, and steroid administration. Now a case presentation: fungal meningitis in an 8-year-old patient being treated for a cervicothoracic neuroblastoma. She later developed acute myelogenous leukemia and during chemotherapy and bone marrow transplantation presented with persistent headaches and fever. In these sagittal and axial postcard T1 images, we can see nodular enhancing leptomeningeal lesions along the brain stem and also the spinal cord. A very rare opportunistic fungus was identified as CSF culture and antifungal therapy was intensified. However, the patient developed hydrocephalus and eventually died. Candida and Aspergillus species are the organisms most frequently identified. Aspergillus disseminates to the CNS hematogenously, most commonly from the lung, causing infectious vasculopathy, leading to acute infarction or hemorrhage, or extend into surrounding tissue as infectious cerebritis or abscess. In neutropenic patients, fungal sinusitis, usually aspergillosis or mucormycosis, may manifest only as mild rhinorrhea or facial pain and quickly progress to rhinocerebral syndrome with invasion of the CNS via the cerebriform palate. 3 imaging patterns have been described in neutropenic patients with cerebral invasive aspergillosis. The first one, cortical, subcortical hypoattenuating areas on CT or hypertense areas on T2 images, multiple ring enhancing lesion, and the last one, dural enhancement adjacent to sinonasal disease. An example of the first one, invasive thoracic and cerebral aspergillosis in a very neutropenic patient being treated with intensive chemotherapy and bone marrow transplantation. This chest X-ray shows bilateral pulmonary infiltrates with a huge bulla on the right side. Axial cranial CT show hypoattenuating areas that correspond to invasive aspergillosis with secondary infarcts. Post-mortem examination of this patient demonstrate aspergillosis in multiple locations. The second type of aspergillosis infections is multiple ring-enhancing lesions like these images. And the third one, dural enhancement adjacent to sinonasal disease. This is an example invasive paranasal and cerebral aspergillosis in an 11-year-old boy with acute lymphocytic leukemia and a bone marrow transplant who was severely neutropenic. He presented with fever, frontal headache, and right proptosis. In this axial CT, we can see ethmoidal and sphenoidal disease with right preseptal and postseptal orbital cellulitis. Sinus aspergillosis was diagnosed and intensive antifungal treatment administered. The patient's condition quickly deteriorated in the course of 1 week with severe headaches, and axial cranial CT shows a hypoattenuating area in the olfactory right frontal lobe. The patient's neurologic status deteriorated and he died in a few days. There is a most teaching point about CNS aspergillosis. Subtle or minimal peripheral enhancement like this image is more common in leukemic patients than a well-defined ring pattern, because edema and enhancement capacity are dependent on lymphocyte and total leukocyte counts. The second type of infection is candidiasis. Candidiasis can also be seen in immunocompromised patients. However, it is rather uncommon beyond the neonatal period. It appears at imaging as numerous ring enhancing micro abscesses less than 3 mm in diameter at gray-white matter junction, basal ganglia, and also cerebellum. The predilection of candida for vascular structures may cause vasculitis, intraparenchymal hemorrhage, mycotic aneurysms, and thrombosis of small vessels with secondary infarction. This is an example. MRI of approved CNS candidiasis show diffuse, nodular, and circular contrast enhancements involving the whole brain. These susceptibility-weighted images show diffuse dotted and patchy low signal intensities, which indicated the diffuse micro-abscesses and micro-hemorrhages. In conclusion, many pathologic conditions affect the CNS in pediatric patients with oncohematologic processes. These pathologic conditions are related to the primary disease, the various anti-neoplastic therapies required for its treatment, including radiation therapy, chemotherapy, and bone marrow transplantation, or infectious complications. Use of modern imaging techniques facilitates prompt diagnosis, which is essential for early therapy and increased overall survival. These are references I use for this presentation. If you like this video, please subscribe this channel. If you would like to get a notification for the next videos, please press the small bell. If you have any question or video suggestions, please write in the comments. Thank you for your attention.